Oh, keep you guys years. No. Thank you so much for having me. And this is a funny story. My daughter Claire, who's probably our youngest, not necessarily our youngest, attendee. Yeah, make her way. And she's actually working for me right now. So anyway, Claire graduated a semester early from University of Illinois and is planning on going to medical school in the fall. I do. She is going. She is enrolled. She's got an apartment. But when she graduated, she said, I think we could maybe go on a cruise. And she has not been on a cruise since her grandparents took us all on family cruises when she was 4 and 6. And so we started looking at a cruise or various cruises. And then the directors contacted me literally within days and said, hey, Dr. Kesslering, would you come and speak at our cruise? And I said, Claire, we're going to be here. So anyway, that's great, and I appreciate the invitation, and of course is one of my passions. And just to give you a teeny bit of background on me, I actually started eating a low carbohydrate diet 24 years ago, and I did it because I had 2 babies, and I was always a kid that struggled a little bit with my weight, and I'm like, oh, I just want to get back into my regular clothes, and this is not really the way that I want to spend my life. But we were talking about having another one, and we were struggling to have number 3. And so I said, forget it, I'm just going to concentrate on me. And lo and behold, do you know that going low carb gets you more babies? So then I had back-to-back the Irish twins. And so Claire was the baby of 4. And pregnancy became a little easier. And then I said, oh my God, we have to stop. Being a doctor and having one in an internship and one during residency, and then one as a junior partner, I guess you could call it, and then one as a partner. But there's never a good time to have babies, but they make your life worth living, right? Yeah. Anyway, so as most of us know, the diet world is super confusing, especially when it comes to cancer. So immediately upon diagnosis, how many people are told to go vegan, plant-based, etc. And I just want us to just open our minds, because I want to talk about what we know and what we don't know. And that's really where I think that the confusion comes. And I think it comes with mantras, right? And I love this conference because I feel like we're addressing a lot of those things. But even from what's a healthy fat to, oh, you have to go carnivore because 0 carb is where it's at. I'll tell you that there are some pitfalls, especially in a cancer world, when we just think it's about carbs. So again, I always go to the American Cancer Society. It's very similar to what they recommend for everybody, right? Lots of plants, no red meat, no dairy fats. 7% saturated fats are still bad even for cancer, and eat lots of fruits and vegetables and whole grains. And again, we can talk about where some of this comes from, but really what is the level of evidence? It's the same. It's observational data. It's expert opinion. It is not randomized data. It is not even looking at the science that we have. It is like they just have such blinders on. So what do we know? Well, certainly we know that a lot of Americans and worldwide now are diagnosed with cancer annually. And 90+%, we hear that cancer is a genetic disease, and I'm going to tell you, we hear all the time, genetics might load your gun, but diet and lifestyle pull the trigger. So why do we have BRCA1 and 2 patients who don't get cancer, right? It's not because they had a gene and it expressed, they're not expressing that gene. So we have to think about, why are these genes turning on or turning off? We know that both the risk of getting cancer and the outcomes from cancer, what is your risk of recurrence or metastases or mortality? We know that they are worse when you are obese. We know that they are worse if you have diabetes. We know that it's worse, and this is studies done in actual cancer patients, that if you eat more cancer or more sugar, you are more likely to have cancer or worse outcomes with cancer. Same with looking at high-glycemic diets. So I don't know if everybody's familiar. I'm sure this crowd is. But again, when you eat things and it raises your blood sugar, the more it raises your blood sugar, that's a higher glycemic diet. And we know that independent of weight, this is where I started getting into it, right? Okay, it's not about obesity. It's really about insulin resistance. So when we take weight out of it and we just focus on insulin, but what does weight tell us? It usually tells us that people have insulin resistance. So we hear all the time, sugar feeds cancer. And then the doctors say, yeah, no, it doesn't. Eat your fruit, eat your vegetables, eat your pasta. But what we know is that it's more than just sugar. What gets that sugar into those cells? So for those who are not familiar with what this is, a PET scan is a positron emission test where they inject radio-labeled glucose, right? So they inject glucose into you, and it's radio-labeled, so it will pick up on a scan. And you can see that it's going to these two masses. This is in the middle of the chest. Those are called mediastinal lymph nodes. So this is in a lung cancer patient who has two enlarged lymph nodes. But if you actually look at the teeny node, you don't really see it on the CAT scan. But it does light up on the PET scan, which is why PET scans are often used, because it will detect smaller things and direct the radiologist's eye to those spots. Now, this is a complicated graph, but what I want to show is those little keys at the top, those are receptors. So you can see to the left the insulin receptor. So when insulin binds to that receptor, it will pull glucose into the cells. And what's been shown is that cancers often upregulate their insulin receptors. So there's tons more insulin receptors, maybe even as much as 34 times the number of insulin receptors. Now, that's not all the time. Sometimes it's barely different, or it's a little bit different, but it doesn't mean it's not taking out glucose. But the other thing is that a sister hormone to insulin, IGF-1 or insulin like growth factor 1, also, along with insulin, can turn on these growth pathways. So when we turn on growth pathways, we are telling cells to grow. Now, that would be why fat cells grow. We tell it to grow and we store more fat, but it also tells cancer cells to grow. So we have to, again, think of it as more than glucose, because sometimes when you eat a very low carbohydrate diet, you actually get into what's called glucose sparing, where our cells don't take up as much glucose. But we don't raise our insulin because we're not trying to trigger storage. So we can lower insulin when glucose can go up a little bit. And so sometimes I'll use CGM to look at people's, is it really high or is it a fake high? Is hemoglobin A1C, which is a 3-month average of glucose, it's not really the most accurate measure. And so sometimes, again, I'll use continuous glucose monitors to look, is it really an insulin problem or a sugar problem? Sometimes it's not. So if we go back to obesity, we know that with every level of increase in BMI or body mass index, so the more overweight somebody is, and again, we had a conversation that BMI is not the best indicator, so it's really more about body comp, but this is what we have in the medical literature, so we have to look at it. But every increase increases a risk of various cancers. And this list grows every year. It used to be like, oh, it's just endometrial cancer, it's just breast cancer, it's just, okay, colon cancer. You know that it's now lung cancer and esophageal cancer. You name the cancer, and it seems like obesity is associated with it. So let's look at obesity, because it's somewhat circular in that obesity causes increases in insulin and IGF-1 and leptin, or leptin-adiponectin ratio is another indicator of cancer, cytokines, inflammatory cells, VEGF, which is something that happens to tell the cancer to grow more blood vessels. And what you can see is that obesity causes those things to go up, and those things, when they are up, they also lead to obesity. So it's like this back and forth and back and forth. And so you can have type 2 diabetes at 120 pounds. So again, they can go back and forth. And I think Maria talked about personal fat threshold, is that we might all have changes in our hormones and these signaling molecules before we have changes in our weight. Or maybe never get those changes in weight. Right? Asians tend to not put on as much fat before they become diabetic. So now to get into a little bit of diet. So if we understand that it's more about insulin and IGF-1 and sugars, and we all know in this room that triglyceride to HDL ratio is another marker of insulin resistance or insulin status. And then we all know that visceral fat plays into that too. So the more visceral fat, the more likely somebody is to be insulin resistant. And you can see here, now this was not done in a cancer population, But what you can see is that a very low carbohydrate or a ketogenic style diet will lower insulin and glucose and triglycerides more. But guess what? They both lower it, right? And if you are comparing to a standard diet, you're going to say, hey, a low-fat diet is great because it lowers insulin, which it does, but not in everybody. Some people are far more sensitive to those carbohydrates, and so they need further restriction. And again, in cancer, I'm not looking for a little reduction. I'm looking for a big reduction. What's our biggest bang for the buck, and how fast can we get there? This was a randomized trial done in a cancer population. So these were in women, ovarian and endometrial cancer, and they were put on a very low carbohydrate ketogenic style diet versus what the American Cancer Society tells us to tell patients. And you, again, can see that both groups did lower these markers, but the ketogenic diet did it better. And if you talk to the women that were in it, they were better satiated. They weren't always thinking about food, right? Because when you eat lower fat, you're constantly hungry. So it was easier for those women to do it. And this is where I laugh when people say, oh, don't eat meat, don't eat. But Jerry, you asked these women what were your top 3 foods, and right, it was meat, eggs, and butter. So feel free. And then we talk about those inflammation markers, right? We kind of said those cytokines can stimulate insulin or can help have an environment that's growing cancer. And this was just an observational study done in type 2 diabetics. But they looked at a number of, I pulled out just a few, but they looked at a number, I think 15 inflammation markers, and then looked at their changes as they went through following a ketogenic diet. And you can see how all of those markers, I mentioned VEGF before, but CRP, I think a lot of us have heard of CRP before because that often goes along with cardiac disease as well. But again, all of these markers are associated or higher in cancer patients, and here we just showed that these go down. But our whole ketogenic diet thing, because now granted, I do see people who said, oh yeah, I went plant-based and then I had these problems, and so then I blah, blah, blah. And most of my clients come to me very organically, right? They're online, they're looking at things, and I looked at diet, and then you came up, or I was looking at metabolic function, listened to Dr. Siegfried, and then you showed up, or whatever. And so I tend to have people who are very knowledgeable or have already come to terms that they want to follow a ketogenic diet, but they don't quite know how to do that. And I'm a little bit stricter in some ways, again, because many times I have patients who don't want to lose weight. They don't want to go on a ketogenic diet because they don't have weight to lose. So we have to construct it a little bit differently for them. And then I also have the population that says, but I'm not eating any carbs. I'm following a carnivore diet and can't, whatever. And so I want to walk through just a few nuances thinking about that. So many of you are familiar with different types of levels of ketogenic diets. And yes, these are therapeutic typically, meaning that you're doing it for this purpose of making ketones as a therapeutic tool. And we know this mostly from the seizure disorder population. But I will personally start most people around a 1.5 to 1, just as a place to get started and say, where are we? Maybe a 2 to 1. It depends on what they've been doing to the time I meet them. And there are some cases where we might go a little bit higher, but I also use, what's another way to get into ketosis? Fast. So we use a lot of fasting, particularly around chemotherapies if somebody's doing conventional therapy, or maybe they just want to. I have some people I say, I just need to break you. They just can't get it. Their sugars, every time they start to fast, they feel terrible. Their sugars are way up. They just need to get to the other side. How are we going to get you to the other side until this becomes an easier thing? So there's a number of ways that we can do that. But again, this is just a basic idea of the different levels that might be used. And based on what foods you're choosing, right? Because there are some people who cannot leave the idea that plant-based is better. So I'm just going to do a plant-based ketogenic diet. Or there are some people who think, oh my God, I just need so much. I need fiber. And if you're not going to let me eat all these grains or plants, what am I going to do? So I tend to favor more of an animal-based or even carnivore ketogenic diet. I find that, and again, this is very limited data, but there is data in oxalates that breast tumors have 7 times the number of oxalates in them than the breast. And again, very little data, but I do think that some of these anti-nutrients are probably doing us more harm than good, but there certainly is room, and it's about level, and it's about how do you clear it, and some of us have genes that maybe, or bacteria that might help us better than others, and some people have so wrecked guts because of chemotherapies and antibiotics and you name it. So anyway, these are very different, and as most, I think Alina mentioned dairy. Dairy is different for different people. Some people just, I'm just chugging it and I make all, and I really try to keep people away from making the desserts and making the replacement foods because I feel like that's just a trap, right? So people are like, I just need a recipe. And I'm like, just eat food. You don't need a recipe. Pick your protein. How much fat is in that protein? Let's figure out how do you want to bring in the extra fat? And because some people, that's so foreign and that's so stressful to them that we have to think about that. So I will also say for my carnivores, not all meat is ketogenic. And I see people I am just pounding meat and I'm just eating more and more meat and I'm eating leaner and leaner meat. And that's not necessarily ketogenic. And what I see in people, and again, this is why I do labs, right? It's not just about what do you see on your blood glucose meter or on just one test of a glucose and ketone daily, but what am I seeing in IGF-1? What am I seeing in insulin? I will commonly see IGF-1 go up when people are eating too lean. And I feel like that's maybe why meat gets blamed for mTOR, blah, blah, blah. So it's more about what are you bringing with that? And I'll show you some slides so that it's clear. And I will also say that all dairy is not equal, because let me tell you how many people are like, yeah, I went carnivore and now I drink a gallon of raw milk a day. I'm like, milk is milk is meant to grow things, grow babies, grow baby cows, grow baby goats. That we don't want to grow things. So when I'm pulling in dairy with somebody, I am saying, please incorporate butter and ghee if you love them as one of your fats. Personally, I really like tallow. But I will also let them bring in some sour cream or some very heavy cream if it's not a problem, because for some people it's a problem. It's either a problem for the overeaters, sometimes it's a problem because there's autoimmune issues, sometimes it's a problem because there's gut issues. So again, we have to be like, there is no one right answer for every single person. Right? Good. So now I just want to go through a little bit of data, and then you tell me, is it better to eat an animal-based ketogenic diet or a high-fat diet, or maybe it's not? You tell me. I'm just going to share some data with you. So this is in prostate cancer and omega-6 to omega-3 ratios, right? So most of us omega-6s, yes, we need them, absolutely, but we do not have to seek them out. We get plenty. Omega-3s, we need to seek them out. So please eat fatty fish. But what they found was that if you took immunodeficient mice and you injected them with prostate cancer, that if you gave them a very high omega-6 to 3 ratio diet, again, probably worse than the average American, but still a very high 6 to 3. I would say, I think the numbers going around is the average American might be at 15 or 20 to 1. So at 26 to 1, very high 6 inflammatory, and the low omega-6, high omega-3 diet of a 1 to 1. So that's a really big challenge to get to. Most people won't get to a 1 to 1, but again, that's probably what we used to eat. And in the high omega-6 diet, they had faster tumor growth rates, larger tumor volumes. PSA was 4 times higher. And in the lower group, so the more optimal omega-6 to omega-3, a 65% decrease in the proliferation index. That means how fast is your cancer growing. And 67% increase in apoptosis. Apoptosis is how do we kill cells, right? So apoptosis is one way that cells die. So that's in mice. But what about in people? So this was called the Cakefish 3 trial. Again, a similar thing, but we get to experiment in prostate cancer patients because a lot of them are put on active surveillance, meaning they have very low risk. We're just going to watch you. But if you talk to any urologist, they're saying, we'll watch you until it's time to treat you. They never say, we'll watch you until you recover yourself or until your cancer. So a lot of my clients definitely have reductions. We'll talk about a case study. But what they did here is they took these grade 1 and grade 2 tumors that were on active surveillance for a 1-year trial, and they put them on a low omega-6, high omega-3 diet. And they added some additional fish oil supplementation to help boost that omega-3. Right? Omega-3s, the ones that we like, come from fish, not from plants. And the control diet was just their usual. Here's what all the cancer patients follow. And what you see, this was looking specifically at that Ki-67 proliferation index. So they actually did a biopsy at the beginning, a biopsy at the end, and looked at how the rate of progression or rate of growth changed. And what they showed was the standard diet did, in fact, continue to grow and increase the proliferation rate. So they weren't growing faster, right? So if you just give standard advice, the cancer progresses and grows faster. Whereas the other group, the proliferation rate slowed down. Now, in theory, that still means baby growth. It just was growing way slower. So can we now observe these patients longer? And that's the only thing they did, right? So they weren't using ketogenic diets. They didn't tell them don't eat grains or sugars or anything else. They just said you need to cut back on the 6 fats and increase your 3 fats. So these are some tables that I give to my clients. And the red bars, so this is only looking at 6s and 3s. This is in plant fats on the left and plant foods on the right. And you can see the red bars are omega-6s and roughly a serving size that's listed there. And then the yellows are actually, I put them in yellow because they're omega-3s from plants, right? That's ALA or alpha-linoleic acid, which we don't convert as easily. Most of us, now some people have genetics that they convert that, right? Many of us cannot convert that as well. And so I usually say don't eat plant omega-3s because if you don't convert them, are they just more inflammatory polyunsaturated fats? And if we look, and again, many of my cancer patients are downing walnuts. No offense to anybody getting the cheese platter because you're eating 4 walnuts, you're not eating plus, but so many breast cancer patients here, or cancer patients in general, oh, but walnuts have the best omega-3 to omega-6 ratio. But I'm telling you, you can't eat enough fish to make up for that omega-6. But if we look at animals, look at how much less, even crappy animals are going to have less omega-6s. So we're going to do much better. And just to point out one thing, which I don't have in a slide, I'm not a huge fan, even though lard and bacon grease are on this, I think lard of our grandmothers were much more tallow-like. And our lard today and our bacon grease today is higher in omega-6s and in some of the monos. But I wanted to make a comment on Lp(a). You can lower your Lp(a). I see clients lower it all the time. And number 1 is you get rid of carbs. Number 2, you get rid of polyunsaturated fats and monounsaturated fats. We constantly hear monounsaturated fats are better than fats. It's just because they can't bring themselves to say saturated fats are better. And so there is actually randomized data in the literature. If you go and look it up, if you replace monounsaturated fats with saturated fats, you will lower your Lp(a). So I find people that follow more Mediterranean style, they just want to eat fish and nuts and olive oil, and that they will raise their Lp(a), even if they're eating a ketogenic diet. And also the people that replace their butter with bacon grease, because I get to eat a pound of bacon a day. So I'm just going to save all that grease and use that as my fat. So I usually say you can have some pork and bacon and sausage and whatever as long as they're clean, but you throw away the grease. Cook your eggs in butter. Okay, so that was a little divergent. Sorry. Okay, so going back to red blood cell, so RBC, red blood cell fatty acid profile in cancer patients. So again, this is observational, but what they found was that cancer patients compared to controls had lower levels of saturated fatty acids. They had higher levels of monounsaturated fats. They had higher levels of omega-6 linoleic acid. They had lower saturation index, meaning saturated fats to monos. And there was actually no difference in the omega-6 arachidonic acid. That's actually the omega-6 we need to turn on our cascades and turn them off. And interestingly, there was no difference in omega-3. So really might it be related to eat more saturated fat. And so many don't eat meat and dairy. And here's a really interesting study out of the University of Chicago that looked at 255 bioactive molecules derived from nutrients, screened for the ability to activate CD8 positive T cells. So these are super important from our immune function. And this is how they use immunotherapy to stimulate your immune function and address cancers. So they took the top 6 and then found very specifically that transvasinic acid, or TVA, performed the absolute best. And what they found was that only about 20% was broken down, so 80% was still in circulation and activated the CD8 positive T cells. And where is this found? It's a long-chain fatty acid, and it is most commonly found in meat and dairy fats, right? And then the researchers literally said, but cancer patients shouldn't eat meat and dairy, so we're not sure what to do with this stuff. I'm like, tell them to eat meat and dairy fats, please. So anyway, so higher levels, patients with higher levels of TVA responded better to immunotherapy. And yet, what do they tell everybody to do? Stop eating meat, stop eating dairy, eat more plants. It's just backwards. So we have to educate ourselves. We have to go into any situation better than what they're going to offer us. So in these next couple of slides, I want to point out a few different responses, or blood sugar responses, insulin responses to various foods. So you may or may not be familiar with this study. This was not a ketogenic study. This was just, we're giving the same meal twice to an individual and to different people. So each participant is listed in a different color. So not all the colors are the same, or it's not the exact same curve every time you feed the same meal to a person. And every has a different response. So you see that brown, really high curve versus the yellow, relatively minimal, right? So different people respond differently to the same foods. And if we look at young, healthy, although I don't know, are there really any young, healthy people? Anybody? But you can see here that now these were divided, and so I want us to be very careful about somebody out there saying protein doesn't raise insulin, or fat doesn't raise insulin, or whatever it is. So you are an individual, please check it yourself. Now, we're not doing insulin curves necessarily, but what you see here is that in theory, young, healthy, probably college-age males, you give them pure carbohydrate and you get a nice high sugar rise and you get a very nice insulin rise. And that actually is a pretty long insulin effect, right? And so in a cancer situation, if we are trying to not have insulin on all the time, then we don't want kids to be eating sugar all the time, right? Now, if they eat pure protein or pure fat, there's very little difference, although there still is a rise in insulin compared to fat. We need protein. We have all agreed that we need protein. We need essential amino acids. We also don't need to overeat protein in order to get our needs met. And so in a cancer setting where we're trying to keep insulin on the lower side and we're trying to keep IGF-1 on a more even keel, we might choose a different construction of that diet than somebody who's just trying to bulk up and lean out. If we take an older population, which was considered healthy, meaning no diabetes or prediabetes, but again, most of us in this room know that might still mean insulin resistance. But this one is only looking at protein versus protein with carbs, right? And where do we get protein with carbs? Most people out there are getting protein, carbs, and fat, but we might, even if we were eating a plant-based diet, we might be getting beans and things that are protein-carb combos versus fat-protein combos. But in this group, we again see a very high glucose response to the addition of carbs to protein, which we would expect, right? You add carbs, you raise glucose. Look at the difference in insulin between just the pure protein and a protein plus carbohydrate, completely through the roof. And so that's a really dramatic. So then we demonize protein. We don't demonize the carbs, right? Oh, protein, bad. Protein with carbs, really bad. This is another one of looking at protein and carbs, and I wish more people studied fat, but unfortunately I really struggle to find that out. But this is another interesting one. So if you ever wear CGM, Again, this is an untreated type 2 diabetic, so you can see that fasting or baseline glucose is pretty high at almost, 160, 150. But when you eat protein, you don't have a glucose rise. In fact, glucose starts to drop. And a lot of people go, yeah, the glucose is going down, but guess what makes glucose go down? Insulin. So interestingly, the more metabolically broken you are, the bigger the insulin swing you get with protein, with lean protein. And then you add carbs on that, right? Because we already talked about how diabetics have more cancer, and obese people have more cancer, and insulin-resistant people have more cancer. And then they go and they eat a high-carb protein diet, which then really gives them a high insulin. So we always have to remember that doesn't equal that. So protein and fat is good in the right context. We don't want to eat the carbs with it. And now I want to just talk real briefly on the difference. So I know this is a little complicated, but what the green and yellow cells are saying is this is how many cells, healthy cells you have. And if you're getting cytotoxic or cancer therapies, we're trying to kill cancer cells. But what are we also doing? Killing normal cells. But what can we do if we bring in maybe fasting or fasting-mimicking diets like ketogenic diets, or even calorie restriction, which is another way to get into ketosis if you're burning your own fat? We actually start protecting more normal cells. You bring those cells down out of a replication mode, and you slow down their growth, and they actually get protected. And when we're talking about the cancer cells, right? We eat normally, yep, we're killing them, but guess what? If you follow some kind of ketogenic style fasting mimicking calorie, we kill more cancer cells. There is data showing much better, bigger cancer kills. Now, granted, limited data, right? Because they don't make money off of us not eating. And they also don't like to tell people don't eat, right? That's scary to them. You have to eat. You have to keep your weight up. There is data in cancer that weight loss equals worse outcomes, but that's unintentional, right? Those are people who can barely get their Ensure shakes down, and they are wasting. But guess what? I've seen many cachectic end-stage cancer patients where I told them to go on a ketogenic diet, and they stop muscle wasting, and they start to improve their energy, and then they're back out living life, and they're like, I'm not dying. But they actually go back and talk to an oncologist or decide not to. And so anyway, I will say that weight loss is different than fat loss. So we have to differentiate, and I try to counsel clients all the time how to talk with their oncologist, what terms to use. Just tell them you cut out sugar and junk food. That's all you have to say. Okay, as long as you're eating enough, great. Anyway, so these are just some summaries of some of the data, and if you're really interested, I do have some courses online where I try to go through data that go through these things. But just as a summary, we know that ketogenic diets or fasting-mimicking diets can increase the effectiveness of therapies, and we have it in many different types of therapies. Now, some of this is mouse data, some of it is human data, some of it is just small case studies, or I shouldn't say case studies, but small phase 1 and phase 2 trials. We know that fasting or fasting-mimicking diets around chemotherapy can decrease the toxicity. We also know that adding omega-3s can decrease neuropathies, can decrease chemo brain, things like that. And then I will tell you, there's a lot of cancer centers out there telling you not to take fish oil during treatment. I'm going to say take it. That was based on one mouse study with a high-dose chemo, and then they said, oh, but like all these anti-inflammatory things look better, so don't do it because that might inhibit the chemotherapy. Anyway, it can reduce long-term side effects. So when women and men are put on hormonal therapy, they become more insulin resistant. So these are things, they get hot flashes, they get man boobs. Let's change what we're eating because that can actually improve these outcomes. And then again, I do believe there's some effectiveness, like when you look at some of the mouse models, that a ketogenic diet may be equal to some of the cancer therapies. But the combination seems like it is 1 + 1 = 4. It does seem like there's an additive or synergistic effect between them. It can, and we already know that ketogenic diets improve metabolism, decrease insulin, improve IGF-1, lower obesity and visceral fat. And one of the investigators basically said that ketogenic diets or fasting-mimicking diets can profoundly reshape our anti-cancer immunity and immune signatures. Why wouldn't they be telling every single person to do this? It just blows my mind. And real quickly on microbiome, I thought this was very interesting. So we talk about bad foods, regular bugs. They put bad bugs in there anyway. But microbiome can directly impact our T cell function, right? T cell immune function. These anti-PD-L1 treatments, which are immune checkpoint inhibitors, they are more effective after fecal transplant, which improves T cell function. So you can see here the control diet. This is overall survival. So the higher the line, the worse the survival. But short-term fasting in these mice were actually just as good as the medication. And there was no real benefit to combining them. And there is some data in the seizure literature. The thought was that maybe the anti-seizure effects from a ketogenic diet came directly from how you changed your gut microbiome. So I'm going to quickly run through a couple cases. Susie is a patient with a triple negative breast cancer. And I'm going to tell you many times, triple negative, you got to eat a plant-based diet. Don't fall for that ketogenic diet. Don't do that, because there was one trial that when they did an unplanned subset analysis showed that there might be a slight advantage to the low-fat diet in the ERPR negative patients. But I'm going to tell you that if you actually dig into that literature, those women had a lower insulin to begin with, and they substantially reduced their insulin in addition. And the control group, they also reduced their insulin, and probably a lot of people getting rid of junk food and stuff. But their final insulin did not even approach the triple negative starting insulin. So I will bring it all back to insulin. But she's a 58-year-old woman. She had an abnormal mammogram and an ultrasound showing a breast tumor and 2 lymph nodes under the arm. She got the biopsy and it did show triple negative, which means ER negative, PR negative, and HER2 negative. Those are 3 receptors that we test in breast cancer. Interestingly, she was a BRCA1 positive patient. And when most of her life, actually I knew her in college, and she always carried a little extra weight, and then I hadn't seen her. We actually didn't even know we were living very close to each other. She found me online, but I now have Kesslering as my last name, not Maker, and she's not. And then we realized, oh my God, we knew each other in college. But anyway, so very interestingly, she had an MRI that showed the 2.4 centimeter breast mass and 2 abnormal lymph nodes. She started a ketogenic diet. And when they went in to do the ultrasound, to do the biopsy and the axillary nodes, they're like, wait a minute, one of those lymph nodes is actually gone, and the other one is really small. But we biopsied it, and we actually can't find cancer there. Wow. Now, whether that was cancer or whether they were inflammatory nodes, right? Because the body's immune system is trying to help you clear the cancer. So sometimes we just have enlarged lymph nodes that are just immune related, but we were quieting things, right? I did a big battery of labs. We started a ketogenic diet. We added omega-3s and vitamin D and some K2 and methyl B. So I also look at homocysteine and methylation. We've heard a little bit about methylation, but methylation is one of the ways that we detoxify our estrogen. Anyway, she did want to go with standard therapy, which again, I would never tell anybody not to do that if that's what they want to do. Sometimes I do recommend it. So she was getting what's called carbotaxol every 3 weeks with Keytruda, but we added fasting around her infusions. And then she said, oh my gosh, I feel so much better. How's this? This is crazy. She tolerated chemo extremely well. Now, most people understand that triple negative can be very rough. Like it just grows. It's not the most responsive. It's like the worst actor of all of the breast cancers. And she couldn't feel her breast mass anymore after the first cycle. Wow. She decided to stop the Keytruda because she hated it, and it was messing with her bowels, and it was messing with her thyroid. She did have a history of Hashimoto's, and she ended up in the hospital for, I think it was for her bowels, and they ended up doing a CT scan somehow, looking, and they couldn't find the breast mass. And sadly, they wouldn't let her stop, right? She's, hey, you can't see it, I can't feel it, can we just go to surgery? And they're like, nope, you gotta finish like all of your 12 cycles before we get there. And then guess what? Then they wanted to go on, because it's triple negative, you have to have adriamycin and cytoxin. Wow. And she said, but I don't want to, I just want to go on to my surgery. And the surgeon refused to do the surgery until she finished her entire course of therapy. And again, she was too afraid to go against that recommendation. So she said, well, I'll just suck it up. I'm still going to fast. I'm still going to follow a ketogenic diet. I will just do everything I can to protect myself while I go through this. She did. And guess what? There was no cancer in her lumpectomy specimen or in her lymph nodes. Then, of course, because the standard is still to follow that with radiation, she went on. But luckily, she had me. And we said, you know what? We're going to find somebody who's willing to do a very short course. So I sent her to one of my colleagues who decided to talk her into a longer course. And I got after her and I said, stop it. She is going to be 5 kidney treatments, and that's it. And she said, oh, but she still wants to do the boost. She gets extra radiation. And I'm like, tell her you're not going to do that. Or say, okay, fine. And then you get to the end of your 5 and just go home. Just say, thank you. It's been great. So anyway, we got her through that. Again, we did a lot of fasting. So if they do 5 days in a row, I wouldn't normally fast them. But if they can get a Thursday, Friday, Monday, Tuesday, Wednesday, we can easily do a 2-day fast, a 3-day fast. Anyway, long story short, she was also talked into her bilateral subpenial oophorectomy for her breast cancer, her BRCA1, but she did decline the additional treatment, thankfully. And then follow-up, she's been great. We have been checking circulating tumor cells, which have always been negative, and she continues to follow with shorter fasts every 3 to 4 weeks. She still does have some mild insulin resistance and mild elevated inflammatory markers, but now we're in the cleanup phase. All right, and real quick, last guy. Okay, Joe. He was a 76-year-old gentleman, and he had a prostate cancer, and he did everything that he was told to do back in 2022, surgery, radiation, PSA dropped to undetectable. Slowly, PSA was coming up. It went from 4, then jumped up to 16. We crossed paths. He just met me at a wedding, then found out what I did, and he came and talked to me, and then next thing you know, he's my client. They recommended hormonal therapy, actually even talked to him, I believe, about chemotherapy. He's, I'm not interested. I kind of want to just work with you first and see what we can do. Fine. Big lab assessment, again, started him on a number of things. He also on the internet said, oh, I want to start these other supplements or off-label drugs too. And I said, all right, fine, let's do it. So if you want to look at the very bottom, see, the first column is his first sets of some of the labs. So I use HOMA-IR. I look at insulin and IGF-1. I look at triglyceride HDL ratio. I also look at triglyceride glucose index, which is another marker of insulin resistance. And then you can see his PSA with doubling, the doubling time, it was doubling at a rate of every 6 months when we met. And then it went down, it stayed, and I always say, you got to put on the brakes before it goes backwards, right? So we put on the brakes, slowed it way down, and then it's been going down ever since. Very interestingly, January. They all cheat at Christmas, can I tell you that? And then it kind of picks up, and they're like, oh yeah, also had some bursitis in his elbow, etc. But bottom line is, over the course of the year, yeah, he lost the initial 30 pounds, but his PSA is down 60%. His PMSA scan, a little bit different than a PET scan, but he had 3 nodes. They were in his chest. Actually went down, so his uptake was 6.5, then down to 3, 5.5 down to 4, 3.5 down to 3, and then a number of other things. So homocysteine, we talked about those methylated Bs, went from 22 down to 12, and I'd like to see it around 7. Vitamin D up, magnesium better, lots of other markers better. So bottom line takeaways, right? Cancer is driven mostly by insulin and IGF-1. The best diet is the one that reduces those in the individual. So think about protein does still have some insulinogenic properties. We definitely want high omega-3s to lower omega-6s. We want to improve our microbiome. Diet and lifestyle is not the only thing that can do these things, right? We got to have sleep, stress, circadian biology, all of those things matter. So thank you, and sorry I went over 1 minute.